This podcast is brought to you by Porphyria, the vampire curse that's all genes and no garlic. Forget ancient curses and mystical bats. This is a very real, very biological condition where a genetic misstep in the heme synthesis pathway turns sunlight into a literal enemy. The porphyrin precursors build up, forcing the afflicted to flee from the sun's tender rays, lest their skin blister and burn in a spectacular, painful allergic reaction. It's a compelling scientific explanation for why some have been compelled to live in the eternal twilight, with the only real cure being a good lab diagnosis.
Welcome back to the Deep Dive, where we connect the pathophysiology to the printout.
Last time, we worked through the big four of microcytic anemias, the ones you see every day. The mnemonic we used was TICS, thalassemia, iron deficiency, anemia of chronic disease, and sideroblastic anemia. We cover the classic patterns from the low ferritin of IDA to the ringed sideroblasts of SA.
We really did. And if you're working up a microcytic anemia, 99% of the time, the answer is going to be found within one of those four conditions. But today, we're talking about the 1%. We're venturing into the territory of the diagnostic zebra, the condition that can look a little like all of them and a little like none of them, the one that gets missed if you're not looking for it.
Exactly. Today, we are pulling back the curtain on a family of disorders that are not primarily hematologic, but can absolutely present a confusing picture on the CBC. We are talking about the porphyrias.
It's a fascinating topic because, as a laboratory scientist, this is where your expertise really shines. The automated analyzer isn't going to flag, "Consider porphyria." This requires connecting the dots between the CBC, the chemistry results, the iron panel, and most importantly, the clinical context. It's a true diagnostic challenge.
So, our plan today is to first understand what porphyrias actually are by looking at the heme synthesis pathway. It's all about the assembly line. Then we'll connect the breakdown of that assembly line to why a microcytic anemia can sometimes develop. And finally, the main event for us. We'll walk through the lab investigation. What do you do when the iron studies and hemoglobin electrophoresis come back normal, but you're still staring at microcytes on the slide?
It's a journey from a broken enzyme all the way to a specialized urine chemistry test. So let's start at the beginning. The heme synthesis pathway. What are we looking at?
The heme synthesis pathway is one of the most elegant and fundamental processes in our cells, especially our erythroblasts. It's an 8-step enzymatic assembly line. The starting materials are simple, glycine and succinyl-CoA, and the final product is heme. Every step is catalyzed by a specific enzyme.
Think of it like building a car. You have 8 stations. Station 1 bolts on the chassis, Station 2 adds the engine, and so on. If every worker at every station is doing their job correctly, you get a beautiful, functional car, or in this case, a heme molecule, at the end.
A perfect analogy. Porphyria at its core is a genetic or sometimes acquired defect in one of those 8 enzymes. The worker at one of the stations is slow or has called in sick entirely. So what happens? 2 things. First, the intermediate product that worker was supposed to handle starts to pile up. This is the hallmark of porphyria, a massive buildup of porphyrin precursors like aminolevulinic acid, or ALA, or porphobilinogen, or PBG.
And these precursors aren't benign. When they accumulate in huge quantities, they become toxic. This toxicity is what causes the classic and often dramatic clinical symptoms of porphyria: severe abdominal pain, psychiatric symptoms, neuropathy, and in some types, extreme photosensitivity, where sun exposure causes blistering and pain. It's a compelling scientific explanation for why some have been compelled to live in the eternal twilight, with the only real cure being a good lab diagnosis.
The second consequence is a potential shortage of the final product, heme. If the assembly line is broken, you might not be making enough. And since heme is the functional core of hemoglobin, you can see where this starts to connect back to our world of hematology. Not enough heme means not enough hemoglobin, which is the textbook definition of why microcytic anemias develop.
Okay, that makes sense. A defect in the heme factory leads to a shortage of the final product, resulting in small, pale cells. So the question is, why isn't every porphyria a severe microcytic anemia? Why is it considered a rare cause?
That is the million-dollar question, and it gets to the heart of the pathophysiology. For most porphyrias, especially the acute hepatic types like acute intermittent porphyria, or AIP, the enzyme defect is partial. The body can usually still squeak by and produce enough heme for baseline hemoglobin synthesis. The rate-limiting step is managed. In those cases, the primary clinical problem is the toxic buildup of precursors during an acute attack, not the anemia. The anemia, if present, is often mild and might even be normocytic.
So the assembly line is slowed but not completely shut down. It's making just enough heme to keep the red cell factory from stalling, but the precursors are spilling out and causing chaos elsewhere.
Precisely. But there are a few specific porphyrias where the anemia is a much more central and defining feature. These are the ones we, as laboratory scientists, really need to have on our radar. The two big ones to think about are congenital erythropoietic porphyria, also known as Gunther's disease, and the extremely rare ALA dehydroxidase deficiency porphyria.
Let's break those down. What's happening in CEP that makes the anemia so prominent?
CEP is an erythropoietic porphyria, which means the defective enzyme uroporphyrinogen 3 synthase is doing its work primarily within the red blood cell precursors in the bone marrow. So the toxic porphyrin precursors build up right inside the developing erythroblasts.
So the factory itself is becoming toxic.
Exactly. These precursors are damaging to the cell membranes. The erythroblasts become unstable and are destroyed before they can even mature and leave the bone marrow. This is classic ineffective erythropoiesis. The few cells that do manage to survive and get out are damaged and have a shortened lifespan, leading to a significant hemolytic component as well. So in CEP, you have this 1-2 punch of a production problem and a destruction problem, all driven by this enzyme defect.
And that will absolutely manifest as a significant anemia. The microcytosis comes from the underlying heme synthesis defect, but the overall picture is complicated by the hemolysis and the ineffective erythropoiesis. You'd expect to see a ragingly high reticulocyte count, nucleated red blood cells, and all the signs of red cell stress.
You got it. The clinical picture is also very dramatic. These are the patients who historically were thought to be the basis for vampire and werewolf myths. They have severe photosensitivity, reddish-brown teeth that fluoresce under UV light called erythrodontia, and often red-colored urine. It's a devastating disease, but from a lab perspective, it's a profound example of how a single enzyme defect can wreak havoc on erythropoiesis.
Okay, that makes sense for CEP. It's happening right in the marrow. What about lead poisoning? I remember learning that lead can cause an acquired sideroblastic anemia, but it also inhibits some of the same enzymes. How does that fit in?
That is a fantastic point and a critical connection to make. Lead is a potent inhibitor of two enzymes in the heme pathway, including ALA dehydroxidase. So lead poisoning effectively creates an acquired porphyria. The buildup of the precursor ALA is directly toxic to the red cell, and the lack of heme synthesis causes a microcytic anemia.
And this is where we see one of those classic peripheral smear findings, coarse basophilic stippling. That stippling is thought to be clumps of aggregated ribosomes that the cell can't break down properly, partly because of the toxic effect of lead.
Right. So if you see a microcytic anemia with prominent basophilic stippling and the iron studies don't quite fit, your brain should immediately go to lead poisoning. It mimics both a sideroblastic anemia because iron utilization is blocked and a porphyria because a heme synthesis enzyme is blocked. It's the great pretender.
This is a perfect pivot to the lab bench. Let's construct a scenario. A CBC comes through with a low MCV, say 72 femtoliters. What's our workflow, and where does porphyria enter the differential?
Okay, so step one is always the rest of the CBC and the smear. You have a low MCV. Is the RDW high or normal? A high RDW points you toward IDA. A normal RDW might make you think of thalassemia trait. You look at the smear, you see microcytes, maybe some hyperchromia. Are there pencil cells, target cells, basophilic stippling? Each of those findings pushes you down a different path.
Let's say the smear shows microcytosis and some mild anisocytosis. No definitive clues. So the next logical step in the workup is the iron panel. we get the results. Serum iron, normal. TIBC, normal. Ferritin, normal, or maybe even a little high.
With a normal ferritin, we can confidently rule out iron deficiency anemia. That's off the table.
Right. What about anemia of chronic disease? Well, in ACD, we'd expect to see a low serum iron and a normal to low TIBC with a high ferritin. Our pattern doesn't fit that either. The serum iron is stubbornly normal.
So 2 of the big 4 are out. Next up is thalassemia. The indices, a very low MCD with a normal RDW and a normal or high red cell count, might be suggestive. So the next logical test is a hemoglobin electrophoresis, or HPLC.
And the electrophoresis comes back completely normal. No elevated HbA2 to suggest beta thalassemia trait, no HbH, nothing.
And this is where we hit the diagnostic wall. We have a microcytic anemia, but it's not IDA, it's not ACD, and it's not a common thalassemia. This leaves us with 2 main possibilities from our TICS mnemonic, sideroblastic anemia, and our new contender, porphyria.
And their iron studies can look very similar, right? In both cases, iron absorption is fine, but utilization is blocked. So you'd expect a normal or high serum iron and ferritin with a high transferrin saturation.
Exactly. At this point, the definitive test for sideroblastic anemia would be a bone marrow aspirate to look for ringed sideroblasts with an iron stain. But before recommending such an invasive procedure, this is the moment where the lab can provide immense value by looking at the clinical picture and suggesting a different path. Is there a history of alcohol abuse or certain drug exposures that might cause a sideroblastic anemia? Or are there any other weird symptoms?
Like abdominal pain? Neurological issues? Photosensitivity?
Precisely. If the clinician mentions any of those, it's a huge red flag for porphyria. And now we pivot from the hematology lab to the chemistry lab. We need to look for that pileup of precursors we talked about. This is where we stop looking at the red cells and start looking at the urine and blood for what's being spilled.
So what's the first test to order if you suspect an acute porphyria, like AIP, which is notorious for causing those neurovisceral symptoms?
The single most important screening test is a spot or random urine test for porphobilinogen and aminolevulinic acid, or ALA. During an acute attack of something like AIP, variegate porphyria, or hereditary coproporphyria, the urine PBG will be massively elevated. It's not a subtle finding, it's often 10, 20, or even 50 times the upper limit of normal.
It's crucial to remember proper specimen handling here, too. The sample needs to be protected from light because these porphyrin precursors are light-sensitive and can degrade, potentially leading to a false negative. The sample should be wrapped in foil or placed in a dark container immediately.
An absolutely critical pre-analytical point. Historically, labs might have done a qualitative screening test like the Watson-Swartz test, which is essentially a colorimetric tube test. But today, the gold standard is a quantitative method, often by mass spectrometry, that gives you a hard number. A hugely elevated PBG confirms the diagnosis of an acute porphyria.
Okay, so a high PBG nails the diagnosis for the acute types. What if the suspicion is for one of the cutaneous porphyrias, like Porphyria cutanea tardae or our anemic friend CEP? PBG might be normal in those cases.
Correct. In that case, you need to look at a different set of tests. The next step is a 24-hour urine collection for total porphyrins. This measures the later stage precursors like uroporphyrin and coproporphyrin. Different porphyrias will have different characteristic excretion patterns of these porphyrins, which can help pinpoint the exact enzyme deficiency.
And for something like congenital erythropoietic porphyria, where the action is in the red cells themselves, you'd probably want to measure erythrocyte porphyrins, right?
Exactly. A total red blood cell porphyrin level is the key test there. In CEP, it will be massively elevated. And finally, the ultimate confirmation for any of these suspected porphyrias comes down to 2 things: direct measurement of the suspected enzyme's activity in red cells, and increasingly genetic testing to find the specific mutation.
This is a beautiful example of reflex testing. You start with a confusing CBC. The basic workup is negative. You use the clinical context to guide you to a screening test like urine PBG. And based on that result, you follow a cascade of more specific tests until you have the final answer.
Let's tie it all together with a quick case. A 40-year-old male patient is admitted with confusion, weakness in his limbs, and severe abdominal pain. His CBC shows a hemoglobin of 11.5 grams per deciliter with an MCV of 78 femtoliters. The RDW is 15%.
Okay, so a mild microcytic anemia with a borderline high RDW. The initial thought might be early iron deficiency.
So they order an iron panel, but it comes back with a normal serum iron and a normal ferritin. Now the team is stumped. An astute laboratory scientist reviewing the case notes the combination of neurological symptoms, abdominal pain, and an unexplained microcytic anemia. They call the physician and ask, "Have you considered porphyria?" They also ask the nurse if the urine in the Foley bag looks dark. The nurse says, yeah, it looks a bit like a dark tea.
That's the key. That's the phone call that changes everything. They send a light-protected urine sample to the lab for PBG and ALA. The PBG comes back at 100 times the upper limit of normal.
And there it is. The diagnosis is acute intermittent porphyria. The microcytic anemia is a secondary finding, a clue, but not the primary disease. By understanding the full differential from microcytic anemia beyond the Big Four, that laboratory scientist potentially saved the patient from unnecessary procedures and got them on the correct treatment path for a life-threatening condition.
It really demonstrates our role as diagnostic consultants. We're not just generating numbers, we're interpreting patterns. Porphyria is the perfect example of a disease where the pattern is subtle and spans multiple departments of the lab. You have to put the hematology, chemistry, and clinical pictures together to find the answer.
So the key takeaway for our listeners, when you're faced with a microcytic anemia and the iron studies and hemoglobin electrophoresis are coming back negative or non-diagnostic, take a step back. Think about heme synthesis. Look for clinical clues of lead toxicity like basophilic stippling or the classic porphyria symptoms. And know that the next step isn't another hematology test, but a well-chosen, properly collected chemistry test.
A fantastic summary. With this episode, we've now gone from the most common cause of anemia on the planet, IDA, all the way to the rare and complex world of the porphyrias. We've officially put a cap on our deep dive into the world of small red cells.
But of course, anemia doesn't stop with microcytosis. What do you say next time we move up the MCV scale?
I think that's a perfect plan, from the small cells to the just right cells.
Join us next time on The Deep Dive as we tackle the incredibly broad and challenging differential diagnosis of the normocytic anemias.